Afternoon, good morning, good evening, good day, wherever you are. We said guten Tag to Dr. Andreas Kremer because he is in Switzerland, but he's from Germany. Have you learned the three other languages that are part of Swiss culture?
Um, well, I adapted to Swiss German in the meanwhile. That runs pretty smoothly. I
Okay.
can speak French. That is okay. My Italian is rather limited to ordering a pizza and paying the bill, I have to say. But I'm working on that. No.
Okay, perfect. Perfect. Good stuff. All right. So, if you're just joining us either here in the room or on Facebook, Dr. Kramer does have an emergent case. So, we'll be keeping an eye on that. And if he needs to excuse himself, then we completely understand. And we're grateful for his time today. That means we will cut it as short as we can, but we will still get through as many questions as we can. And we will go immediately to the quick fire round. So, question, so there's a bit of background in terms of not had never been offered a fibroscan, diagnosed back in 2006. Now Professor Jones talks about fibroscan quite a lot and says it's part of the picture, but only part of the picture. And then in Facebook chat rooms where patients get together to talk, they will come together and have different experiences and share those experiences. So, with all that in mind, and before I ask you the question, I've got to say the caveat that what we're doing here is we are answering questions and giving general information and not medical advice. So, anything that's discussed here should not at any point replace what is happening with your consultant, but hopefully would empower your conversations. So, with all of that said, I'm going to come back to Andreas and ask you, can you provide your opinion of regularity of fibroscan within a treatment plan? And what expectations should PBC patients have with regard to their hepatologist providing that service?
Yeah, thank you very much. So also a warm welcome from my side. So good morning, good day, good evening, wherever you listen to us. FibroScan is a machine which measures liver stiffness, so-called elastography. And other machines can do that as well. There are many ways of measuring the elastography. It can be the transient elastography as FibroScan does it. It can be 2D shear wave elastography as many sonography machines, for example, from Siemens, Toshiba, Canon, and others, or GE do that. It's a simple method to have a rough estimation how hard the liver is. A healthy liver is very soft. And the more we have liver fibrosis, so the more collagen, the more fibrosis is produced in the liver, the stiffer, the harder the liver will be. And what does now this elastography measurement do? It sends in a wave and gets, let's say, the echo back. And the quicker this echo comes back, the stiffer, the harder the liver is. And this is an indirect measurement of liver fibrosis. And this has been validated in particular by many other liver diseases, in particular viral hepatitis. But there is now more and more data that it also works quite well in patients with primary biliary cholangitis. And we recommend it as, yeah, let's say an additional measurement, an additional way to investigate the quality and damage on a liver, irrespective actually on the underlying liver disease. And we have learned that the more fibrosis we have in the liver, the worse is the outcome in the end. That means the higher is the risk for development of a liver cirrhosis, for the need of liver transplantation. So that's why we would like to treat our patients more intensively if we have hints that there is more and more fibrosis in the liver. And those patients can now be identified without taking a biopsy, which is very nice for our people with PBC, because we don't have to repetitively perform these biopsies, which are invasive. I think personally they are very safe, but still it's invasive, and there can be potential harms to a person performing a liver biopsy. And in that regard, we and the novel guidelines recommend to do that at least once a year. If you have a very good and smoothly running PBC with, let's say, a normalization of alkaline phosphatase, I don't think that it's really necessary to do that on an annual basis. But once in a while, I think it's a very valuable additional information we receive. And that's why I would recommend to go to a hepatologist or gastroenterologist or ask this person whether this could be done. Maybe you could be referred to another hepatologist who has such a machine. It has to be kept in mind that there are influencing factors which result in false high results. And this is, for example, inflammation. If we have inflammation in the liver, this can be false high. If we have a cardiac problem, that the blood flow to the heart is reduced, that there is, little bit of, right heart dysfunction, and there's more blood in the liver than normal, this can also result in significantly increased values. And purely having a good meal and going then to the hepatologist and performing that will result potentially in significantly increased value. So you have to do that fast and no inflammation, no other inflammation. Then I think it's a good parameter. But please keep in mind, don't have a breakfast, even don't drink a coffee beforehand. This can really influence it, because more blood from the gut will go to the liver, and just the increased blood flow rises liver stiffness. So this has to be kept in mind. But then it's a good and reliable measurement, in particular if it's repetitively done. And don't interpret it too much. So if you once have 6.5 and the next time you have 7.5, don't be concerned. There is a variability and so on. So I mean, only repetitive measurements over a longer time period are really indicative of a disease which is progressing.
Yeah. Okay, perfect. That's helpful. Thank you very much. So I'm going to say congratulations, not to you, Andreas, unless there's something we don't know. The question has come, so somebody just found out that they're pregnant after being diagnosed with PBC over a year. So the first thing we have to say is that PBC, as a rule, doesn't make you pregnant. So let's clarify that first and foremost. But in a more serious vein now, what does this mean for my pregnancy? What should I prepare for my pregnancy to be like? And do I need to take a lower dose of urso?
Yeah, very good question. Congratulations, of course, from my side as well. I would like to mention here that as long as you don't have an advanced liver cirrhosis with portal hypertension, pregnancy with a PBC is a very safe issue. There are no reports that you or your baby is at risk, or your unborn baby. So we recommend to continue ursodeoxycholic acid treatment with the very same dose throughout the pregnancy. Don't stop it. Don't reduce the dose. I think that you have a likelihood that you will see the very best liver values at the end of the pregnancy, because it's an immune-mediated liver disease. And the immune system is calmed down during pregnancy, because 50% of the fetal material is not belonging to your body. It's it has different aspects regarding immunity aspects, and the immune system does not recognize it, doesn't attack it. And we don't have a full understanding how that works, but we know from these immune-mediated diseases that they often improve during pregnancy, and they may result in a flare reaction after delivery. Not necessarily, but what we know is that when we stop URSO, that a flare reaction may occur. And that is the reason why we certainly do not want female persons during pregnancy to stop URSO, deoxycholic acid treatment. I would recommend to additionally measure to the regular lab values bile acid levels, and should they significantly increase above 40 micromolars, in particular at the end of the pregnancy, then you should rediscuss that with the hepatologist and gynecologist. But otherwise, this is very safe, and yeah, nothing to worry about.
Okay, perfect. Thank you very much. So wonderful news all round. So many congratulations, and hopefully that will now be stress-free. So, okay, I was diagnosed with AIH with possible PBC overlap 2 years ago. On my 2-year review biopsy, PBC was the predominant process and AIH was in remission. Now, I don't know where you are with PBC and AIH, and I know where many of the other clinicians are. They said that my ALP result was within range, but they could see features of PBC on my biopsy. So can we talk a little about the difference between histological and liver biochemistry? But they've said they've started URSO, but they're now wondering, how will they know if the ALP, how will they know if it's working if the ALP is already within range?
Yeah, I mean, very interesting case, and I think the first aspect we should mention here is that if autoimmune hepatitis is histologically in remission, I presume that transaminases are also normal under the immunosuppressive therapy. And if we have alkaline phosphatase normalization on top of that, this is really an excellent treatment response. Now, the inflammation, in the liver is very difficult to judge from a written report. And we have every Friday our pathology meeting where we look at every single biopsy we take. Okay. And in that regard, I wouldn't overrate that damage. I mean, if some kind of damage is there, then the question is whether this is clinically meaningful. So my question would be, to get a better understanding of such a biopsy, is how much bile ducts are lost. So do we see signs of the so-called ductopenia?
Yeah.
And if the bile ducts are present in every portal triad, in every portal field, then if there are some inflammatory cells around it, but if they are there and if they are not highly damaged, which I would presume with a normal alkaline phosphatase, then I would just accept that as part of the underlying disease. But these histopathological, written reports, I always recommend it's necessary to have really a look. The hepatologist together with the pathologist interpret that. But from a laboratory response, and this is what we know in regard to outcome, the best thing you already have achieved, that is normalization. And so I personally think the URSO dose is correct. You have normalized, the immunosuppressive drugs are adequate, you had to have a good response, and I wouldn't overrate then the biopsy results. The question would be, to me, why was a biopsy taken? Because normally, if we would have a normalized laboratory pattern at our center, we would not take another biopsy because that would be sufficient for us. So the question is there any other reason why there is inflammation? Is there any other additional underlying disease? Is it, for example, a so-called steatotic or previously called fatty liver disease, which may contribute to such an inflammatory component, for example? But this is very difficult. But these are just my questions, sent back.
Okay.
But otherwise, I mean, from a clinical perspective, I wouldn't intensify the therapy or change anything with such a laboratory result.
Okay. Now, given the AIH is a potential player as well, would it be sensible to have another biopsy further down the road, or would you use lab markers?
If you have no cirrhosis or very advanced fibrosis, we don't take repetitive biopsies, except for the few patients where we would like to stop immunosuppression.
Okay.
But stopping immunosuppression means that we have a monotherapy, a low-dose monotherapy regimen for more than 2 years, and then you could argue, okay, look, I would like to stop my immunosuppression. Can we take a biopsy? And if we don't say any signs of autoimmune hepatitis, then the probability that this works is much higher compared to those patients where we see residual autoimmune hepatitis activity in the liver biopsy. So this could be one reason. Otherwise, we think the laboratory pattern and the total IgG levels are quite good indicators of an adequate treatment response. So if IgG and transaminases are normal, so ALT and IgG are normal, that means I have a likelihood of way more than 90% that this is adequately treated.
Yeah. Okay.
And
Perfect.
on top of that, it has to be mentioned that some of these so-called invariant syndromes, or previously called overlap syndromes, so autoimmune hepatitis and PBC, have been misinterpreted. I personally think there are many patients with an overlap syndrome, which is only an initially maybe, suboptimal or untreated PBC, which is a little bit more aggressive and results in histological features which could resemble autoimmune hepatitis. But so this should always be kept in mind, that it could only be PBC initially. And in that regard, if now there are no hints for autoimmune hepatitis, I would dare maybe to taper immunosuppression and maybe completely stop it if it's only a single treatment regimen at this stage. This is, I think, valuable or adequate to do or try.
Okay. All right. Perfect. Thank you. A couple of very quick fire questions. PBC and supplements. Patients had colonoscopy, diagnosed with polyps, which were removed in diverticulosis. What they've read about this advises a high fiber diet and aloe vera for a healthy colon, but they've not managed to find any information about aloe vera and PBC. Is it contraindicated?
I personally have to admit that I don't know anything about positive or negative effects of aloe vera on PBC, at least to my knowledge. Maybe Robert, you know more. But I have not heard anything negative on that. I mean, aloe vera is used for many aspects, and I wouldn't consider this to be contraindicated if a person suffers from PBC. So if you have the feeling that this is good for you, for your digestion, or you treat obstipation with that, and that helps, that makes a loose stool, I'm happy. I think a fiber-rich diet is always good. I think in general, a fiber-rich diet is very healthy and very important, not only for the avoidance of diverticulosis and or colon cancer, but I think there are no real good investigations for underlying liver diseases. So I think it's okay to use aloe vera.
All right, perfect. Thank you. What about a patient with PBC and cirrhosis who's looking to drink non-alcoholic botanical drinks? I'm not even sure I know what that means.
Well, botanical drink sounds a bit, yeah, I don't know what I should imagine
Yeah,
among
it could
such
be
a drink,
anything. Yeah,
but I think, of course, I mean, alcohol-free beer or alcohol-free other fermented juices, whatever it is in the end, are okay. Please keep in mind, I always say these drinks may contain quite a significant amount of fructose. And
yeah,
so this results in overfeeding, too much calorie intake, and too much calorie intake results in a fatty liver, and now called steatotic liver. So where too much fat is in the liver, and this would be an additional risk factor if a person has already PBC. So in that regard, if once in a while such a drink is taken, I think that is not an issue at all. But if that is very regularly done, I think it should be worthwhile looking at the amount of calories which I additionally take to myself.
yeah.
And the same holds true for smoothies and fruit juices and everything. I mean, if we eat 2 oranges or 3, our stomach is full, we don't want to have anything else. But if we take a glass of orange juice, which is squeezed out of 3 oranges, we continue with the whole breakfast, and this makes the big difference. I think, eating fruit is okay. Drinking these things should only be done once in a while.
Okay, perfect. Okay, thank you very much. PBC and triggers. Do we think that sepsis could be a trigger for PBC?
Yeah, I mean, this is a very good question. I personally, I'm not fully convinced about the different hypotheses we have why a PBC develops in a liver.
Okay.
There is the hypothesis of a molecular mimicry saying that our immune system gets in contact with certain bacteria. And these bacteria have proteins which resemble in structure that of proteins in our small bile ducts. And then our immune system, after such an infection, not only attacks the bacteria or potentially also viruses, but then after this infection now also attacks the small bile ducts. This is a molecular mimicry hypothesis, or whether we need first a genetic and local damage in the bile duct system, a disrupted biliary protection, biliary umbrella, which then in turn results in a local inflammation, which then may be triggered by additional factors such as a sepsis or a bacterial infection. Very difficult to say which is first, the egg
Yep.
or the chicken. So
Yep.
I don't know. In the end, I cannot answer this question. It could be that certain bacterial infections result as a trigger in a person with a genetic background which is prone to develop an immune-mediated liver disease. So I think we need various factors, namely host factors, genetic factors, which are necessary, and then an immune system which from a certain point on just attacks something in the liver. Why this is now the case remains a little bit unresolved at this stage.
Okay, perfect. Thank you very much. I appreciate that. PBC and cholesterol. What can you tell us? We've got a patient who has raised cholesterol. Um, Due to various ailments, etc., they're not keen to take a statin. So, what can you tell them about PBC and cholesterol, please?
Yeah, I think it's important to know that hypercholesterolemia is commonly seen in PBC. And the question is this now a problem? Is this potentially dangerous for a heart attack, arteriosclerosis, and so on? Or is this only a bystander phenomenon which goes along with PBC but is not really a risk?
Yeah.
And the current knowledge says that if you don't have an additional risk factor for cardiovascular events, such as arterial hypertension, smoking, diabetes mellitus, the metabolic syndrome. If this is not present, then we would currently not treat hypercholesterolemia in PBC patients, because we have learned that lipids form, which are normally secreted into bile, they accumulate in lipoproteins, a so-called lipoprotein X, which runs in the low density fraction of lipoproteins, the LDL fraction. And these LDL are, always termed the bad cholesterol. And now we have a cholesterol which has been proven not to be atherogenic, not to cause this risk, but this runs within this fraction. If we do the assay, we cannot differentiate how much real LDL is there and how much LPX, this, PBC associated lipoprotein, is there. This is a very sophisticated method to distinguish that from the proteins which are running with it. So we cannot say anything about that, but we only treat if there are additional risk factors, such as diabetes. Family history is also something. If the father or the mother has had an heart attack at an age of 60 or even younger, then I would treat that. Otherwise, if this is a pure lab value, we wouldn't treat it.
Okay, I'm with you. All right, perfect. That's helpful. Thank you. So talking about kind of other risk factors. So somebody has been told that if and when a transplant happens, it will help stop the itching and it will extend life if everything goes well, but it wouldn't do anything to help their other autoimmune conditions, so such as scleroderma, Raynaud's, all of those kind of things. Is that the case?
Yeah. So to dissect that a little bit, yes, liver transplantation results in relief of itching. This is quite impressive. The next day, patients wake up and say, "Oh, this is still a horrible situation here on the intensive care unit, but the itching is gone." Yep. So this is quite impressive. This is true. So if liver transplantation is necessary, this should, of course, be done. At an end-stage liver disease, there are many criteria for that, but this, in principle, not only relieves the symptom burden of itch, it also resolves the underlying disease, PBC. So a healthy liver is there, and PBC is gone, and itching is gone. Fatigue is something which has to be kept in mind, that this may, at least on a mild to moderate level, may remain. But otherwise, I think in particular itching is dramatically improved. Now, regarding other associated underlying diseases which are immune mediated, they are not changed by the situation that we replace a liver. So, of course, we give immunosuppressive drugs, and some immune-mediated diseases may respond to this immune suppression, but from the experience we have, that many immune-mediated diseases are not significant modulated by that. And on top of that, the good thing about the liver transplantation is that we only require a small amount of immunosuppressive drugs. We often have patients with a single monotherapy. Tacrolimus, for example, monotherapy is often sufficient. And so the immunosuppression is not very impressive. And that's why I personally think we don't treat then efficiently other immune-mediated diseases.
Okay, that's helpful. All right, thank you very much. So similar question in terms of other risk factors. I'm going to ask you about men in PBC in a second. So firstly, how often do men have PBC? What's the risk factor compared to women, that kind of thing. So I'll ask you to speak about that in a second. But my second question related to this is we have a man with PBC and AIH overlap. Brother's daughter also had PBC who recently had a transplant. So does this raise a red flag for his children or grandchildren? He doesn't want to panic them, but should they get checked? And if so, what should they ask their doctor?
Yeah, very good point. I think PBC male patients are diagnosed later because we have learned in our textbooks it's a female predominance. This is true. 9 out of 10 patients are female, but this results in a later diagnosis of PBC in affected male people. And that means that the disease is often further advanced compared to female persons, which then results in a higher risk for disease progression and potentially worse outcome. If we correct the stage of the disease between female and male patients, then there has been data that there is no significant difference anymore. But this doesn't help a male person who is diagnosed with an advanced fibrosis and PBC, because then he has already this advanced disease stage, which is more difficult to be treated.
Okay.
If we have now familial PBC cases, which is not very common, I have to admit. This is a rare situation. I would definitely look very carefully with an expert hepatologist or a referral center into that, whether there are additional underlying genetic diseases involved or genetic alterations which results in this increased prevalence of PBC. But of course, I would definitely screen the next generation for the presence of autoimmune antibodies, so antimitochondrial M2 subunit antibodies, and look for liver tests. So look for transaminases, for cholestasis parameters. And I would do that even if negative. I would offer such families that to do that on an annual basis to control for liver tests, just to have the opportunity to catch a potential disease very early.
Yeah, perfect. All right, thank you very much. I'm aware of time, so I'm just going to pull another couple of questions, if we may. So the background is slightly confusing. I've had my PBC since my early 20s and have been very stable on urso, but then they say they've only developed cirrhosis this year. So that's kind of thrown me, and I don't fully understand that. However,
I just have to answer one phone call. I'll be right back in a second. Sorry for that.
No, that's fine. We will mute Andreas. Hopefully, this isn't a call with regard to his young male liver patient who's just had a transplant and is fighting at the moment a challenging situation. So while Andreas is doing that, I can talk to you about what's coming up in December. So our Choose Me Tuesdays are still going on. So this is where you have a space like this in Click Meeting. So it's no longer on Facebook, it's in Click Meeting, and it's a proper meeting where everyone can talk and everyone can hear and everyone can interact. And it is all about your self-care. So how you are on a day-to-day basis. And we'll look at the emotional, psychological, and physical aspects of living with PBC and living your best life with PBC. So we're hoping that you'll come and join us for those. On top of that, we will be continuing with our Q&As. Keep an eye out on our YouTube channel. So we've called it PBC TV. Now, I know in the US, there seems to be a new TV series which has the acronym or the initials PBC, which is kind of killing our YouTube rating at the moment. But if you go on YouTube and look up the PBC Foundation, or go on YouTube and look up PBC TV, PBC Foundation is better. You'll find us quicker. But we have lots and lots of these Q&A sessions all recorded. We have some sessions from our patient conferences, all of those kind of things. So they're all there. They're all ready for you to watch and to listen. And you can just put them in the background. And if you're doing something else, you can listen away whilst you're multitasking. On top of that, we have the Bear Facts coming out very, very shortly. So that will give you, again, a chance to read. Now, the Bear Facts is a quarterly magazine. If you don't get it, check with us, because you might have ticked the box when you joined to, or might not have ticked the box to get the magazine. So if you want to get the magazine, then please do make sure that you do that. On top of that, we have our app as well. So please do come and use and download our app. It's free to anyone who's registered with us. And it's an opportunity for you, again, to look after your own self-care. So whilst we're here, I'm just going to look at... now that's interesting, because Andreas is still on Facebook. Giselle has typed test. But the questions are all coming in, which is fantastic. Okay, so there's lots and lots to talk about the kind of familial link. Now, again, just to reiterate what Andreas said earlier before he comes back, and if he doesn't come back, I'm sure he'll let me know that he's been pulled away. So, oh, there we go.
Okay. So I have a couple of more minutes, but then I would have to leave.
Okay, we fully understand. So I'm going to ask this question just because, again, it's somebody who has cirrhosis, and so would like to help them as much as possible. They've been diagnosed this year with an autoimmune skin condition called bullous pemphigoid. The blisters are intensely itchy. Now, they're much improved now, but the question is it related to their PBC, and do you have any other information that can help?
Yeah, I mean, the pemphigus is even much more rare immune-mediated disease where these blisters may form. And indeed, I have to admit that I've only seen that once, but I know that from my colleagues of dermatology that this is a very itchy disease. And to my knowledge, I have no clue how the current guideline recommendations are of this special dermatological immune-mediated disease. Typically, it was treated with steroids, with topical steroids, even with systemic steroids. There is, to my knowledge, not a clear association between both diseases, but this is more likely due to the fact that the dermatological disease is so rare that it would be difficult. We would have to have worldwide registries of these pemphigoid patients to see whether there is maybe an increased number of PBC patients among this very rare dermatological disease. Treatment of itch in these patients is rather treating the underlying dermatological disease. If that is improved, and that is what our patient told us here, that this seems to be improved, and then itching is also improved. With a PBC, of course, we never know whether some kind of residual or itching may be due to the PBC. In that regard, if the skin is okay, if there are no blisters, no inflammation, but itching is still there, then I would consider to add an anti-itch treatment for PBC and to see whether this helps and improves. Link here regarding treatment or pathophysiology.
Yeah. Okay. Thank you. Are you still there? Yep.
Yes.
Okay.
One last final question, Robert.
Thank you very much. It's important I ask you this because of your speciality in the clinic that you have. I'm going to combine two questions into one. So one patient is talking about pins and needles. The other is talking about a slight numbness or tingling in the feet that can build up to a strong burning sensation that reaches up the legs and hips. So they both say that they don't have itch per se. However, what can you say about these symptoms, about their relation to PBC, and how to manage it?
Yeah. I mean, when we carefully ask people with PBC for the burden of these sensory alterations they experience, we often hear, and I often hear, it's not a pure itch. I have burning, stinging, biting, whatever. Many analgesic components, pain components.
Yeah,
Um, so what I rarely hear is a non-itchy patient having these pain components only.
yeah,
And if I have that, then I would always think, is this really purely due to PBC, or could anything else contribute to this sensory um, alteration? Could be polyneuropathy, for example, associated with diabetes mellitus. It could be a small fiber neuropathy. This
yeah,
is a new disease entity which has only, the last 10 years been described in more detail, which can only be diagnosed by a neurologist checking for the sensor, objective sensory testing, and then in the end, a skin biopsy where this nerve fibers are quantified.
yeah,
And I would do a further workup on that to clearly at least exclude potential other causes, for example, for polyneuropathy or painful sensations.
yeah,
If they have been excluded, I tend to treat those patients with anticonvulsive drugs such as gabapentin or pregabalin, because they have been licensed to treat neuropathic pain. So if we
hmm,
have an injury, a nerve injury, and then these painful sensations remain, they are very, very helpful and they're licensed for that. And
yeah,
in that regard, we also use these drugs to treat the itching. But personally, I think it could well be that we rather treat this, you know, an agonizing, painful components and maybe less the real itch component, so that we
yeah.
rather treat the algogesic component, and this results in a benefit. So I would give that a try. Be Keep in mind it's purely renally excreted. It doesn't bother your liver, but look at the kidney function. If kidney function is altered, you may have to adapt the dosage. And secondly, it needs time. You will not experience a benefit within 3 to 5 days. It needs time, patience, and a stepwise up titration of the drug. It has a very broad therapeutic range, so you can start with low dosages and then stepwise go up um, to the clinical data which has been published in trials. 50% of the maximum dose was used in these trials, and then they were very efficacious. So
Yeah.
when we talk about gabapentin, for example, the 100% dose is 3,600 milligram. And now
Okay.
there are many colleagues who start then with 100, 200 milligrams or 300 milligrams, but you see that this is rather than 5 or 10% of the maximum dose. And if that then doesn't improve anything, I always say, yeah, well, it's just too little. It's like a UDCA dose of 50 milligram or 100 milligram. That wouldn't also help. So we have to titrate that up if it's well tolerated, of course. But we should rather reach 1,800 milligrams to have an adequate treatment effect. So this has to be kept in mind.
Okay. Wonderful. All right. Andreas, thank you so much for your time. I know you have to go. I will probably not see you now until the new year. So I wish you however you celebrate, a wonderful festive period, and we'll see you soon, my friend.
Robert, it was a pleasure to discuss again with you the needs and questions of our listeners.
Thank you.
And I also wish all of them a very enjoyable pre Christmas and Christmas time. And of course, all the best for the next year. And highly appreciated that this opportunity here stands, and we are looking to talk to each other in 2024 again.
Indeed. All right, you take good care. All right, go and look after that patient. Bye for now.
Take care. Bye-bye.
Okay, so with apologies, Andreas has had to run off, but hopefully that will help. And I hope this session has been of help to you. So I will say cheerio to the people on Facebook. So I bid you well, and we will see you coming up very soon. All right, take care.